journal in the world. I also want to remember that the webinar for today is supported by an educational grant from Wire Incorporation, and it's a pleasure to show you our program. On the next slide, you'll see we're going to have Professor David Tingay from Melbourne, from the Murdoch Children Research Institute, and then Professor Tobias Werther from Austria. So it's a good, I'm very happy with everything, but particularly to present you with David Tingay, which, by the way, beside being professor in Melbourne, as I said, and beside being one of the biggest experts in the world about neonatal respiratory physiology and an active researcher, particularly in the translational field, is a good friend of mine, and this makes me very, very happy. So I'm giving you David Tingay. David, the podium is up to you.
Thank you so much, Danny, for the very kind introduction and the opportunity to speak at this webinar. I'll just share my screen and we'll get started, and I'll say some more then. And I'm hoping now you can see my presentation. Is that correct?
Yes.
Thanks. Once again, Danny, thank you for the very kind introduction, and it's fantastic to be at this webinar. It's just a shame, like all of these things, we can't do them in person as much as we'd like. I'm really quite honoured to be speaking before Tobias, and I'm looking forward to hearing what Tobias has to say about forced oscillation. I've been asked to talk a bit about work of breathing in neonates, and do we really need to worry, or does it really matter? So before I start, I'd just like to say I have no conflicts of interest to declare and nothing to disclose with regards to this presentation. And I'm here in Melbourne in Australia at the Murdoch Children's Research Institute, and I would just like to acknowledge the traditional owners of the land that I'm working on, who are the Wurundjeri people of the Kulin Nation, and pay my respect to their elders past, present and emerging, and extend those respects to any other First Nations people who may be listening to this presentation. My objectives in the next 15 to 20 minutes are just to discuss firstly the concept of work of breathing and a little bit of a revision on physiology, to highlight some of the specific challenges that may be present for neonates during the course of my presentation, and then to discuss why I think understanding work of breathing is important in terms of how we apply invasive mechanical ventilation and provide some practical rationale for that, and then non-invasive respiratory support, where we have less data to support our practices, but probably where it's more important. And then very briefly at the end, I would like to highlight some of the potential new novel methods of quantifying work of breathing in neonates, which may help us in the NICU, and hopefully will provide a framework for discussion in the Q&A. So work of breathing relates to our understanding of the physical concept of work, which is defined as force times distance. In the respiratory system, force is the product of pressure and area, and volume is the product of area and distance, which means that we can translate the physical understanding of work into one in the respiratory system, where it's defined as pressure by volume, or the product of pressure and volume, and it's usually defined in a unit of energy, joules, divided by a unit of volume, such as litres or millilitres, or as a product of power, which is the work rate of the system. That I think is actually quite hard to understand, and I don't think it has a meaning for most of us clinically. What it really means is we're talking about the energy that a person needs to use to support ventilation and gas exchange. And for most of us, the respiratory work of breathing is actually quite low and only accounts for about 5% of normal oxygen consumption. Clearly, a failure of work of breathing will lead to respiratory failure, because we won't have the petrol or the juice required to allow the continuous movement of the respiratory system to occur efficiently, and that will impair gas exchange. Practically, for our patients, what work of breathing means is it's the work or energy we require to firstly overcome the resistance in the respiratory system, to allow gas to move into the chest and support ventilation. And that resistance is multifactorial. It occurs in the airways, it occurs in the tissues, and it also refers to the resistance in the compressible intrathoracic gas. There is another aspect of the respiratory mechanics we need to overcome to allow breathing to occur or ventilation to occur, and that is that we also need to deform the elastic tissues in the chest. So we need to provide enough energy to the respiratory system to allow us to overcome chest wall and lung recoil. Now, chest wall recoil is quite interesting because generally the chest wall will inflate without any muscular energy, which means that we're not using energy within the chest wall recoil to support breathing. It's simply in lung recoil. And the energy that is developed in the chest wall is actually potential energy in inspiration, which can then be released as energy in expiration, allowing expiration to be more energy efficient. So essentially, we've got three components to work, two of which require energy and one of which allows us to release energy in expiration. The chest wall recoil means that for most of us during tidal breathing, we've actually got very minimal active muscular contraction occurring. But that is slightly different in neonates because of the impact. There's minimal impact from the ribs on volume change during ventilation in neonates and a much greater predominance on the need of the diaphragm. Now, most of you will be aware of this, that when we think about work of breathing, we can convert this into the Campbell's diagram, which breaks down the different components of work of breathing into the work required to overcome the elastic properties of the lung, which is here in blue, and that's a positive work or active work in inspiration, and the work required to overcome the elastic properties of the chest wall, which is where our elastic recoil occurs for the passive work in expiration. And the energy being exploited to generate inspiration is shown here in blue, and then the energy from passive recoil is in the red color. But of course, that doesn't take into account resistance. And if we add into resistance, we start to see a diagram that many of you may be more familiar with, where we need to build in the components of resisted into the work being used to overcome the elastic properties of the chest. And if you're needing respiratory support, there may be further imposed resistance in the system, such as during if you have an endotracheal tubing or the type of non-invasive system that's in place. For many of us, we're probably used to a figure like this, which is essentially the Campbell's diagram, which has been rotated 90 degrees. For our babies, they need to generate the energy during ventilation to overcome these both the resistive and the elastic properties of the chest. And this is what the baby needs to do to be able to ventilate if they're not fully muscle relaxed. Clearly, if our disease changes, we will change the work that's required, because the amount of pressure required, for example, in a low compliance state like RDS or surfactant deficiency, is going to need to be significantly greater to generate a normal tidal volume above FRC. And as you can see here, the curve related to work of breathing has now changed. We need a bigger pressure, as you'd expect, due to low compliance, but also the area under the curve, or the amount of work or energy that's required, has now increased, so that the energy needed for a baby who has active surfactant deficiency to support breathing is going to be much higher than a term baby who's well. Practically, for us at the bedside, this means that during invasive ventilation, the work of breathing that a baby needs to have to support adequate ventilation will be related firstly to the lung mechanics and the lung disease, and it will then be related to any imposed resistance we've placed on the baby with regards to our mode of respiratory support and any devices that are placed in the baby, and also any other components that might be going on, such as chest wall edema, abdominal compression, and other states of reduced chest movement. We need to be aware that there's loss of glottic and chest wall control for most of our babies when they're invasively supported, because they'll have some degree of sedation and they'll have an endotracheal tubing, which will increase which will alter their work of breathing needs, because they will not be able to use expiration as a way of supporting FRC as well. And the disease that has resulted in them having needing respiratory support may well increase their basal metabolic rate, and this will result in greater need of their oxygen for energy support in other parts of their body, which means that they may need to have a higher FO2, or we may need to consider sedating the patient to try to reduce the oxygen consumption due to respiratory support. Interestingly, I think most of us have been taught that the endotracheal tube, at least when I was a trainee, that the endotracheal tube is a significant component of imposed work of breathing during respiratory support for neonates and small children. And in fact, the data doesn't necessarily support that. There's very little imposed work of breathing, at least in benchtop models of neonatal lung conditions, if an appropriately sized endotracheal tube is in place. Note that I use the phrase appropriately sized. That can change if you have an inappropriately sized tube. And there's negligible difference if the ET tube is trimmed or not trimmed in terms of imposed work of breathing. That's not to say that there isn't significant imposed work of breathing from respiratory support during mechanical ventilation. And that's what I'm going to talk about now, because it comes from the other aspects of respiratory support, the pressure and the flow that we're delivering to the system, particularly in expiration. I think most of us have accepted, and quite rightly accepted, that we should be trying to synchronize babies and encouraging them to breathe when they are on invasive respiratory support, because we know from meta-analysis of the existing clinical trials that if you apply synchronization to preterm infants, you have a shorter period of invasive support, you have a shorter period of time in hospital, and at least you don't increase BPD, and we may well be decreasing it. More importantly, numerous studies across all age groups have shown that synchronization improves patient comfort and is less likely to result in greater need for sedation and so forth. So if we take the rule that we should be synchronizing our babies, then we need to understand that during a synchronized breath, which you can see is the first one here in this row of inflations, both the patient and the ventilator are contributing to tidal volume change in the chest, and they're also contributing to a degree to flow change in the chest. And this is the reason why a synchronized breath is generally going to have a lower delivered PIP than a ventilator-only breath or inflation during mechanical ventilation, because the patient is contributing some of the energy which is required chest during inspiration. So if we're going to use synchronization, we then need to understand that there will be a work of breathing component applied during that support that the patient needs to, we need to consider. And let's have a little bit of a think about the sort of work of breathing that might be imposed on the patient during different scenarios of mechanical ventilation. Here we can see some ventilator waveforms for a patient who is totally asynchronous with the ventilator, and in red, shown there in the middle, you can see an asynchronous pressure being PIP being applied by the ventilator. And we can see here some degree of volume change occurring. It's truncated though, a small amount of pressure change occurring, and positive flow. But what we're seeing immediately after is the patient having an asynchronous spontaneous breath that's occurring during expiration and is actually resulting in no volume change, almost certainly because there's a component of splinting involved. Here, this patient is exerting energy without any change of volume in the chest. So this is a wasted inflation. It's going to result in an increased work of breathing, even without the imposed breathing from the ventilator is going to work, and that's going to impose greater metabolic needs on the patient, and it's also going to impose a level of discomfort. So we don't want to see this because of the impact it's going to have on the patient. Here in the next waveform, we can see a better synchronized series of waves, but we can see, as highlighted in the blue circle there, that this patient is taking a breath during the expiratory phase of the of ventilation, or of the mechanically delivered ventilation. We can see a well synchronized inflation occurring just prior to that, and then just as it gets back, the flow gets back to zero flow, we can see the patient is taking another breath during expiration. There's no subsequent real volume change occurring for this. So again, we've got energy that's being exerted without a positive result on the patient. And This is going to increase the baby's work of breathing. It's going to lead to discomfort, and we should be trying to avoid this. So this clearly shows that what we want to do is to have something more like these sort of waves, where we see that every breath is well synchronized. There's no asynchronous inflations occurring. And in this situation, both the ventilator and the patient are delivering some pressure into the chest to move it. And the pressure that the ventilator is delivering will actually be helping to unload some of the work that's required from the baby rather than fight against it. So I think this is fairly clear in terms of the clinical data, but also in terms of the physiology, that we should be trying to use synchronization for every single inflation, because it's likely to reduce the work of breathing that we're asking our babies to use while they're mechanically ventilated. Of course, one way to synchronize a baby is to have a baby on SIMV, and I'm generally averse to using SIMV as a sole mode of ventilation. And I think my rationale for that actually comes back to considering the concept of what does it mean for the baby in terms of the work the baby has to do whilst they're intubated if they're on mechanical ventilation. So again, on the left here, we can see a baby who is on SIMV with a backup rate, but is breathing above that backup rate, which is what most of us would generally want to happen. And we can see that there are some well-synchronized inflations, but we can also see that the baby is having to take some breaths, or is taking some breaths that are not supported by the ventilator's positive pressure. So they're having to generate flow without any support from the ventilator. In those inflations, the volume change that's occurring in the chest is having to be done by the baby, but with the imposition of the ventilator circuit and the ventilator itself, which is imposing a positive flow of gas on the chest, and also a pressure change or PEEP on the chest. So this baby is having to work harder during these non-synchronized inflations than during the synchronized ones. If in this baby we turn on pressure support, which we can see here, and it's the following waveform where we have SIMV inflations with pressure support for the non-SIMV inflations, we can now see that we are generating some degree of delivered positive pressure change, which is much lower during the non-SIMV inflations. And so that we are at least attempting to unload the imposed work of breathing during these inflations for the baby. So for my practice, I think this is a strong rationale to either have every single inflation supported in all babies when they're mechanically ventilated and they're able to spontaneously breathe. So I tend to either have babies on assist control SIPPV or patient triggered ventilation, depending on which ventilator manufacturer you've got. They have different names, where you are you're attempting to synchronize with some PIP change every single breath the baby is wanting to have. Or if I can't use that, I would advocate using SIMV with pressure support for the non-SIMV inflations. The question then comes, well, what do we do when the baby's outside of the acute lung disease phase? This is all pretty easy when the baby has acute lung disease, because they need that pressure to help support tidal ventilation and to support their lungs during active disease. But most babies spend most of their time on a ventilator actually in a weaning phase. And in that situation, then the question is, well, what PIP or pressure above PEEP do we need to be providing to take away the imposed work of breathing related to being on a mechanical ventilator, or to elastically unload the chest in a more efficient way? And we have some data to suggest that gives us some guidance for that. This is now old data, which is a crossover trial that was conducted by Bancalari's group in the US, where babies were crossed over to SIMV when they were in a stable phase of needing mechanical ventilation for RDS. They were preterm babies, so they were either on SIMV or they had SIMV with pressure support being 3 centimeters of water above PEEP. So in the breaths that are not SIMV breaths that the baby take, if the baby takes an inflation, the ventilator would give a PIP effectively of 3 centimeters of water above the set PEEP. or a pressure support of 6 centimeters of water. And they saw that there was considerable elastic unloading at a pressure support of 6 compared to 3. And more importantly, markers of ventilation efficiency were significantly reduced when pressure support of 6 was used compared to having no pressure support. So this suggests to us that at least a pressure support of 4 centimeters of water, or a PIP above 4 centimeters of water, is required in preterm babies to help unload the elastic components of imposed work of breathing from being on that ventilator. And again, reinforces why most of us would never allow a baby to be on ET Cpap for prolonged periods of time. There are other reasons as well. The group then went on and looked at in a small randomized controlled trial comparing SIMV versus SIMV with pressure support. And I think we could really translate, turn SIMV with pressure support here into assist control. They're effectively fairly similar in what they're attempting to do. And they could see the time to extubation was significantly reduced when pressure support was added as the only difference in the ventilator strategy. So again, moving towards making sure that every breath the patient takes on a ventilator, which they are initiating energy for or doing the work for, is getting some help from the ventilator to help unload the work or energy components related to being on that ventilator. Another thing to think about whilst you're mechanically ventilated and you're using synchronization is the role of the trigger setting on the ventilator. So here we can see on this ventilator, I've blown up the flow wave, and you can see here the trigger is set very low at 0.2 litres per minute. And we can see in this synchronized inflation, there is a transient difference between when a baby starts a breath and when the ventilator starts delivering supported pressure during inflation, or the PIP. And during that time, the baby's work is having to breathe in with all of the imposed components of the ventilator and the ventilator circuit on the baby's breathing effort. So if you set your trigger very low here, then the work of breathing the baby takes is shown here in red. The higher we set the trigger, the more work of breathing the baby needs to exhibit without any support from the ventilator during the inspiratory cycle. So again, this reinforces why when you're synchronizing babies on mechanical ventilation, you need to ensure that your trigger is as low as possibly manageable for that baby. And that requires some clinical observation in terms of looking at how the baby is interacting with the ventilator and considering whether there needs to be any sedation to help the baby trigger effectively or not. High frequency is slightly different. And here is some benchtop data showing that the superimposed Cpap and the high gas flows in high frequency can have an impact on work of breathing, and that's dependent on patient size. Fortunately for us, looking at neonates, which is the bottom left here, there is actually very minimal imposed work of breathing, at least in benchtop settings, for the neonatal lung conditions we would manage on high frequency. The problem comes in when you start looking at larger, and some of these will include term babies, and then into pediatric practice. And this is why we often need to provide some sedation to larger children and infants on high frequency because of the level of discomfort and the imposed work of breathing that comes from being on high frequency in that group, but not for the very small babies. I'll now speak on non-invasive ventilation work of breathing. We know that Cpap decreases the respiratory muscle overload in bronchiolitis, or infants with bronchiolitis. In preterm babies, we have quite a bit of data, but it's all very small small observational trial data generally, up until one recently produced trial. So in preterm babies, we know that a variable flow Cpap condition system versus a continuous Cpap flow system reduces the imposed work of breathing across a range of PEEP settings. And we can understand that, because in a variable flow system, in expiration, flow is taken away, so the baby doesn't have to breathe, expire against flow. Similarly, variable flow Cpap has less resistive work of breathing and less laboured breathing in a small observational trial of preterm babies compared to bubble Cpap. There is some evidence that the interface may be quite important in some of the bench testing, with higher resistance interfaces and narrow expiratory tubes increasing work of breathing, and I'll get to that in the next slide. Interestingly, again, in observational data, there's very little difference between Cpap at low peaks versus high flow at flow rates that are generally used in clinical practice in terms of imposed work of breathing from the interface itself. And as we would expect, if you have synchronized non-invasive positive pressure ventilation, there should be reduced resistive, elastic, and imposed work of breathing compared to just Cpap alone, because you are attempting to offload some of the work that's occurring in inflation or inspiration by the patient. And again, at least in animal studies, we have evidence that NAVA reduces work of breathing compared to non-invasive ventilation. And we need some more trials that consider some of the benefits of NAVA, because I think that's quite exciting. More recently, we've had probably the only really decent quality randomized controlled trial in preterm infants, which has looked at work of breathing or a system specifically designed to reduce the imposed work of breathing during Cpap on clinically meaningful outcomes in preterm infants. And this is the CORSAD trial, which came out of Europe, and it studied a reasonably large population of preterm infants, and they were randomized to a new Cpap interface for resuscitation and delivery, in which attempts to apply a less imposed work of breathing and still allows resuscitation with PPV to be applied, versus standard mask TP system. And the primary outcome was intubation or early death in the delivery room. And this showed that there was a reduction in the primary outcome of early intubation or death in the delivery room, which was highly significant, and I think is probably clinically meaningful. And at least it emphasizes that we do need to think about our interfaces, and it may be more important than we often think in clinical practice. One of the things that I think is really unknown is what is the impact in non-invasive ventilation on work of breathing of different PEEP levels. We know that if your PEEP is too low, you have atelectasis, and you would have a reduced FRC and poor lung compliance. And we'd expect then that the work of breathing needed to achieve tidal ventilation would go up if our FRC and our compliance have impaired. And similarly, if we increase our PEEP too high and over-distend the lung, we would expect that whilst the FRC will go up, this compliance will go down, and that will mean that we'll have to work harder to achieve our tidal ventilation to overcome the problems related to over-distension. But we have very little evidence or information on what PEEP levels actually impact on work of breathing in preterm infants. We have a number of old trials which have shown that firstly, some level of Cpap appears to decrease work of breathing, imposed work of breathing from a circuit compared to no Cpap alone. We have an interesting study, which is now quite old and very small, but took very detailed measurements of breathing patterns, in particular the laboured breath index, which is a good marker of work of breathing, in preterm babies who are moved from 0 up to 8 centimetres of water, and showed that generally work of breathing decreased as Cpap was increased. And then more recently, we have a larger study which has compared Cpap levels of 4, 6, and 8 on ventilation efficiency in preterm babies, and showed an improvement in efficiency when PEEP was moved from 4 to 6, but very little subsequent improvement when it was set to 8 centimetres water. The limitations in interpreting all of these studies are that these are essentially studies done in very well preterm babies who are pretty stable, and that often non-invasive ventilation is used for different reasons. And we don't yet know whether there will be an exact PEEP level that will translate into one particular baby being more efficient or less efficient. And here is where we need to start thinking about better clinical trials. And also we need to start asking ourselves, well, how do we measure work of breathing at the bedside, particularly during non-invasive ventilation? Because if we're going to say work of breathing may be important in understanding whether a baby can maintain appropriate non-invasive ventilation, we need to know how to measure it. And the answer, unfortunately, is that it's very hard. Most of us judge work of breathing the way we were taught to do it in medical school, which is to look at the baby and look at how hard they look like they're breathing. And it's questionable how accurate we're all at that. There was a study from about 7 years ago, and again, an observational study from here in Melbourne, and combined with a Dutch team, who showed that simply measuring tidal volume, peak inspiratory flow rate in babies who were preterm babies who were on Cpap shortly after birth did appear to be associated with an ability to predict their subsequent Cpap failure in early life, with, as you'd expect, lower peak flows and lower tidal volumes more likely to result in Cpap failure due to fatigue, as signs of fatigue. I think we can probably do better than that, and measuring tidal volume and peak inspiratory flow during Cpap or other forms of non-invasive ventilation is particularly difficult and itself is invasive, in my view, and will impose some work of breathing issues. One thing we can be aware of is that the neonates are more reliant on the diaphragm, and we have got better methods of measuring the diaphragm. Probably the most established and easy to perform would be bedside point of care lung ultrasound, looking at diaphragmatic function. We know that diaphragmatic thickness changes with gestation. So if you are going to look at diaphragmatic function, you need to, measuring its thickness alone needs to be contextualized in terms of the gestational age of the baby. We also know that the motion or normal motion of the diaphragm changes during spontaneous ventilation and mechanical ventilation. So whilst we have no studies so far that have looked at whether diaphragmatic ultrasound can predict work of breathing subsequent failure of non-invasive ventilation, it's entirely feasible to do so, and we have good normative data to help devise that. More recently, we've had an increase in the use of EMG as a way of measuring diaphragmatic function. Obviously, this is a system that's available on the NAVA as part of NAVA, and that involves an invasive esophageal probe, but we now have a number of transcutaneous commercial EMG systems that have become available. And a recent study in pediatric research from the London group in 48 preterm babies showed that measuring transcutaneous EMG during a spontaneous breath test before extubation was able to demonstrate that just placing a baby on ET Cpap increased the EMG amplitude by about 50%, which suggests, as you'd expect, that the babies are having to work harder because they've had the PIP reduced, which suggests that this method of measuring diaphragmatic function is probably a proxy of work of breathing for the patient. And they're able to show that in less than 29 weeks, which was a small group, and this does need to be looked at in a much larger trial setting, that babies who failed had a different pattern of EMG prior to failure compared to those who successfully did extubate. So again, these are small studies, but as these technologies become available and easier to use, it may provide a way of quantifying work of breathing in the future. So I hope I've shown that work of breathing at least is important, that ventilation modes should aim to minimize work of breathing, and the best way we could do that is to use full synchronization, that optimum synchronization requires understanding the impact of work of breathing on the baby in terms of triggering and how to set our synchronization. Work of breathing is likely to play an important role in non-invasive failure, and that non-invasive systems may have different imposed work of breathings depending on the specific system that's being used, and that we are going to need to develop better ways of quantifying work of breathing in our babies. I thank you for your time. I'd just like to advertise our trial that we're undertaking, which is a trial of PEEP in the delivery room, PEEP levels in the delivery room for preterm babies. We have a number of EU sites and UK sites involved, and we've been really, really proud and happy to have all the EU sites involved because they've been so fantastic to work with so far. And if you are interested, then I'd be very happy to hear from you. Thank you very much.
Well, thank you, David. First of all, I would like to say hello from Madrid and give thanks to Danny De Luca to give to me the possibility of being with all of you. This is the first time I'm here in the ESPNIC, and I represent the new neonatal critical care section. I'm the chair, and I think it's going to be a very good news that we are going to have more and more neonatologists or people dedicated to neonatal critical care. So after this amazing talk, we have now to keep on doing this webinar, Tobias Werther. So Tobias is a German-born person that is an Italian citizen who is currently a neonatologist at the Department of Pediatric in Pediatric Intensive Care and Neuropediatrics in the University of Vienna. So she's a nice researcher about many different topics. He is right now a professor at the Medical University of Vienna, also senior neonatologist, and he has begun his career not many years ago. So he's a very young investigator. So the topic he's going to talk and discuss with us is a very provocative topic for all of us who has been dedicating most of our time to respiratory physiology and mechanical ventilation, and it's to talk about oscillometry and mean pressure titration in extreme preterm babies. So thank you, Tobias, for being with us, and the floor is yours. Welcome to the webinar of the ESPNIC.
Yeah, hello everybody, and hope you can hear me all. Thank you very much, Manuel, for this kind introduction. I say good morning, good afternoon, and good evening to the world. We have a lot of listeners all over the world, so that is very challenging for me. I'm also very happy to be in this group, in this outstanding group of researchers. And many things I'm going to talk about rely on findings from David Tingay, also from Daniele De Luca, and also from Manuel Sanchez Luna. So I'll start with my presentation now. May I see my slides? Okay, just one moment. I don't see my slides, Rosa. Okay. Do you see my slides now?
Yes, we do. Thank you.
Perfect.
Oh, perfect. Yes. Thank you. Okay, yes, I will talk about oscillometry and mean average pressure titration in extremely preterm infants. These are my disclosures, and these are the learning objectives to describe lung recruitment maneuvers guided by oxygenation during high frequency oscillatory ventilation in preterm infants, and I will talk about the forced oscillation technique, and especially the forced oscillation technique as a future parameter to guide lung recruitment maneuvers during HFOV. Let me start with a case example. This is about a 23-weeker born in 23+3 best postmenstrual age by cesarean delivery. There was a premature rupture of membranes at 21 weeks of PMA. The mother got the antenatal steroids, and after birth, we needed to intubate this tiny little infant in minute 3. There was practically no breathing effort, and we administered surfactant at 25 minutes of life, and then we had the baby already on HFOV, and these are the settings you see there. And I think this is an example many of the neonatologists come across with, and you know this is a very vulnerable phase, and we have to really take care of this little baby. Well, here is some data. We do know that at least, or about 50% of the extremely preterm infants need mechanical ventilation at some point. And especially the very small ones, 23, 24 weeks, is about 1/3, at least in our cohort, needed to be intubated already in the delivery room or in the first day of life. So ventilation is indeed a big issue in this cohort. And why it is so important, we know that mechanical ventilation induces or triggers bronchopulmonary dysplasia in these babies, and especially when you ventilate them for more than 7 days, they are on a high risk to develop PPD. So we need to think about some lung protective strategies, and there is a lot of pathophysiological explanations out there, and about ventilation-induced lung injury, and we know that over-distended parts or athletic parts are very critical, and in particular, the shear stress in this in this lung units cause inflammation, and if possible, we should avoid all those deteriorating situations. And this is a figure where it kind of summarizes how we should look for lung protective strategies. And These are these famous pressure volume curves. And when you are on the inflation part, it's like an S-shaped curve where you start in a de-recruited units, and then you end up in a zone of over-distended units. And this has to be avoided if possible. So you should stay, when you're doing ventilation, within the safe window here, avoiding zone of overdistance and also avoiding zones of atelectasis. And in very sick lung, this safe window can be very, very narrow, and it is difficult to prevent from lung injury. And there is high frequency oscillatory ventilation coming to the game. And I don't want to talk about all the benefits and drawbacks of HFOV. I just want to say a few basic words. It is kind of a, if you want super Cpap, it is a standing pressure which you impose to the lung, a continuous standing pressure, and you're imposing to this standing pressure oscillatory tidal volumes at a frequency of about 10 to 20 hertz, so about 600 to 1,200 times per second. And this oscillating signals, they take care of the CO2 elimination, while the standing pressure takes care of the oxygenation in a very simple way. And there is some agreement, or there are some hints that high frequency oscillatory ventilation gives you a good opportunity to stay within the safe zone compared to conventional mechanical ventilation, in particular in situations where you need a high positive inspiratory pressure. And this might also, there are also some data out there who nicely describe this difference between conventional mechanical ventilation and HFOV. For example, in this slide, you can see in the middle alveoli exposed to conventional mechanical ventilation, and during inspiration they are getting ventilated and probably a little bit over the standard, but especially during expiration they were collapsing. This is marked by these flashes here. Whereas during high frequency oscillation, you have a continuous standing pressure keeping the small airways open, and also keeping them open in an expiration phase. So there are some physiological explanations why HFOV might be a little bit better than conventional mechanical ventilation. And this has been summarized by experts in statements like, in moderate to severe diseases, it might be easy to stay in the safe zone of lung expansion using HFOV compared to lower frequency modalities. But this is not all about high frequency oscillatory ventilation. It's not the miracle, it's not the solution to all of it. It's important, you need to combine it to an open lung strategy. And meaning that when you're doing ventilation, you should have an open lung. And there are seminal works already more than 30 years ago by McCulloch and his colleagues, who nicely showed in a adult RDS model that when you use a high volume strategy during HFOV, then you end up with a much better mechanical system compared to a low volume or conventional mechanical ventilation. So there are a lot of pathophysiological hints, and especially, and you should especially try to do respiratory ventilation with an open lung. We have also to say that this is not just about HFOV. You should also open your lung when you're doing positive pressure ventilation in using conventional modes. Also, this has been nicely shown by the group von Anton von Kamm and Burkhard Lachmann, where they show then a high volume strategy in both modes, positive pressure ventilation or HFOV, reduces lung injury. But the question is now how to open the lung. How could we eventually open the lung? And this is also a big issue in the adults. And here again, you see the pressure volume curve, and CT scans at different pressure levels. And you see when you are in the inflation limb, raising your pressure, how the lung is getting opened. And what you also see is when you're going back on the deflation limb here, then your lung stays open until a certain point. So at the same level of pressure, there is a big difference between the inspiration, the inflation limb and the deflation limb. Once you have opened the lung, there is a good chance that the lung remains open. This has also been shown on the microscopic scale here by Di Rocco and colleagues, and where they show that looking at the alveoli on the inflation limb, you see how they are getting open, and on the deflation limb, they are indeed staying open until a certain point. And all these concepts, and all these findings on how to open a lung has merged to this diagram here. It is recommended to open the lung until you reach a certain point where you think your lung is now opened, and you go back on your deflation limb until you have the impression that your lung is collapsing again. You reopen it because you should always stay on the deflation limb when you then end up with your final pressure value, which should be a little bit above your closing pressure. And the big question is now, okay, we now have quite understood how to open the lung, or what kind of opening procedure we should adopt. But the problem is, when do we know that the lung is open, and when do we know when the lung is closed again? And there are basically 4 ways of measuring this. There is the lung function in form of pulmonary gas exchange, like the oxygenation or even CO2. There are different imaging techniques. There are respiratory mechanical parameters and intrapulmonary gas volume measurements. Many of those are still research topics, but particularly pulmonary gas exchange as a surrogate for lung function has been established. And this goes back to quite some studies in about more than 30-40 years ago, where it has been shown that oxygenation, PaO2, for example, is a very good parameter for lung volume. So it is kind of linearly related to lung volume, even in small infants. And so oxygenation might be used, and is indeed used, to guide the lung volume and to guide recruitment parameters. Now, using oxygenation as a guiding parameter, there is the next question on how to reach the open level of the lung. Should we do it stepwise, or by little increments of the pressure? Should we do it by inflation, or by sustained inflation, or by repeated sustained inflation? And there's a nice workout by the Australian group with David Tingey and Peter Dargerwell, Colin Morley, who showed that when you're using a stepwise approach, you end up with a better oxygenation at the end. So the stepwise approach is also quite recommended for lung recruitment. And a little bit earlier already, the group by Anton van Kaam, they have used this stepwise oxygenation guided approach in very small preterm infants right after birth, and they could nicely show that it works, it is safe, and you can indeed reduce oxygenation. They used it prior surfactant application and even after surfactant application, and what they could show is that yes, you need quite a lot of mean airway pressure, about 20 or even further centimeter water, so you should not be afraid of using these high pressures. And after surfactant, You don't need any more of these high levels, but again, you do a recruitment and you end up with a optimal opened lung. So this has been showed by the group from Anton van Kaam, and it is safe and it is quite adapted in when you're using high frequency oscillation. In a nice review last year by Ackermann, Klotz, Henschel, Thome, and again Anton van Kaam, they described how you can or how you could do this recruitment maneuver. You start with increasing by about 2 millibar until the oxygenation gets that doesn't improve anymore. Then you go back stepwise until your oxygenation deteriorates, and then you reopen it and you stay a little bit above your closing pressure. So this is a maneuver which can be recommended during HFOV. Now, going back to our example, we are also doing these recruitment maneuvers, not just at the beginning, but whenever we have the impression that there is some kind of lung collapse worsening the respiratory situation. So here we did this recruitment maneuver, as just explained. And we not only just did the recruitment maneuver, we did also a lot of measurements around, because this is part of a study. We also looked at the lung volume using electrical impedance tomography. And what you see on the left side here, that the lung volume is increasing. We didn't need a lot of steps, and it is decreasing when we go back. And at a level of 6 centimeter water, we had the impression that the oxygenation got worse. So we reopened it again, and we stayed at 8 millibar as our optimal pressure. But when you look at the oxygenation in this case, on the right side, you see on the bottom the FU2. It hasn't been changed at all. So there was no way to change it, because the saturation stayed within our target saturation. We started at 92 and ended up at 95% saturation. So there was not a lot of a gain, just 3%. The whole procedure lasted a little bit more than 1 hour. So a lot of effort just to gain 3% of saturation. This is sometimes difficult to convey people to do a recruitment maneuver if you don't see any kind of improvement, or just a little bit of improvement in your oxygenation. So we looked a little bit deeper into this case, and we wanted to understand what's happening here. And on the left side, you see the volume, normalized volume measured with the electrical impedance tomography. You see the blue line, how it is improving, and on the black line, how it is, how the volume is cutting down until you reached a level where you oxygenation is deteriorating and you reopen. The nice thing about electrical impedance tomography is that you can also look inside the lung to some extent, and you could try to look at it locally. And what we see here is how the lungs are getting a change during this maneuver. And blue means the lung is gaining volume, and red means the lung is de-recruited. So during this maneuver, you see that how the lung is open quite everywhere, except for the ventral right part. And you see at the end that the ventral right part is still de-recruited, it is red, and the left upper part is nicely recruited, it's nicely opened. So how to read these images? Is this correct, what we see there? Yes, it is. We did also a lung ultrasound. It's a very nice tool to do bedside monitoring of your lung. And what we saw here is that the right ventral part prior to recruitment was kind of overinflated. There is some indication that it's overinflated. And especially the left ventral part is atelectatic. So this that what we see after recruitment is that in lung ultrasound, the pleural line is quite smooth to some extent. And we have, in a way, homogenized the lung, and that is nicely seen also in your EEG. So there has been an improvement of your lung condition, which is not really seen in the oxygenation. So the question is oxygenation the best or the correct parameter to guide recruitment? But there are already some studies out there that it might be not the optimal one. And this again by the group from Van Kam and David Tingay also included, but they repeated this study by McCulloch, and they showed that when you adopt a high volume strategy and for in high frequency ventilation in preterm lamps, then oxygenation does indeed improve at the end. But what they also found is when they compared high volume versus medium volume is that on a in the histological examinations, there was not a difference or almost no difference between those two levels. And also when it comes up to lung mechanics after this, after the trial, there was not a big difference in those two, approaches between medium and high lung volume. So the question is, they posed some question in this paper whether the lung was already injured too much, and but also maybe oxygenation is probably not the perfect tool to guide recruitment maneuvers. And this question is not completely new, of course. Yes, there has been a lot of discussion also in the adult community, and here I just want to state one statement from the Dean Haas from 2015, saying that recruitment maneuvers and PEEP should be used within the context of lung protection and not just within the context of improving oxygenation. So let's look for other tools to monitor lung recruitment, and here I come to the forced oscillation technique. What is the forced oscillation technique? The forced oscillation technique is a tool, is a method applying very short signals of high frequency to the lung and using the response of these signals, using the pressure and volume responses to determine some mechanical parameter via an inverse mathematical model. And what kind of mechanical parameters do we get? We get information on the resistance but also on the elastance in form of the so-called reactance. So what we measure, what we get out is the reactance. And what we know is that, and I will see it in the next slide, that reactance is nicely related to the compliance of the lung. And indeed, this has already been shown in other studies, but Jane Pillow and colleagues have done this also in preterm lamps, and they first showed that this kind of measurements, so the forced oscillation technique does indeed work, and the results you get are indeed very promising because they do reflect the compliance of your lung. And the measurements are easy to perform once they are implemented in your respirator. And so this gives you the opportunity to do this kind of measurements and to get a little bit of an impression of your compliance of the lung. The group from Raffaele De Lacca, they have done a lot of studies on this issue. And in one nice study, they even showed that when you use the FOT versus for guiding your PEEP level in an RDS model, you do better with respect to lung injury compared to the oxygenation PEEP tables from the RDS network. So this is a hint that our forced oscillation technique can indeed be used to guide ventilation strategies. The same group, but also including David Tingay, they did a very nice work on animals, and they used this forced oscillation technique on HFOV for recruitment maneuvers, and they show that it can be done. It's completely safe, and it gives you different optimal pressure levels compared to the oxygenation, when you use oxygenation as the steering tool. So this also shows that FOT might be a parameter to guide a recruitment maneuver. The same group again did measurements now in preterm infants, in very preterm infants, and they did again show that it works. It was safe in this very vulnerable cohort, and they showed, as you see in this figure here in the lower part, that the compliance, as expected, is decreasing when you're approaching your open mean average pressure, because you are most likely already in the over-distended parts, and it's getting better and better when you are de-recruiting the lung on the deflation limb. Obviously, you see the same behavior you've seen this behavior of the oxygenation, because it was oxygenation guided lung recruitment. So oxygenation is improving, and this stays stable on the deflation line. Well, we did the same measurements now in our case, and we had, as you have already seen, our EET measurements giving us an impression of the lung volume. We know that the oxygenation did not change much, a little bit, but just a little bit. So it gives us the impression there has there has not been a real benefit doing this recruitment. But when it comes up to the FOT measurements, you see nicely that it is that when you open up your lung, it is staying constant or even getting worse a little bit, but it is extremely improving when you are going back on the deflation limb, saying that you are optimizing your lung on the level on the compliance. So this is just one case, but we did 45 measurements in 42 very preterm infants, and we saw that it works perfectly. It doesn't put the infants on any risk by doing a FOT measurement. And FOT is getting worse when you are opening up the lung, and it is improving when you are deflating the lung. And you end up with improved reactance value after the recruitment maneuver. So this, in either direction, your recruitment maneuver does improve your oxygenation, but it does also improve your compliance measured by the FOT. And here now we repeated the figures which have been published by Zanin and De Lacca, and we could confirm that this kind of measurements do work in also extremely preterm infants, and we used the FOT version implemented in the Fabian respirator, and so it is commercially available. And we could indeed reproduce the findings showing that the FOT parameter the reactant does indeed decrease approaching the open level, and does indeed quite improve when you are deflating your lung. Finally, I will show you this this data. We did compare these measurements at different stages. On the left side, you see recruitment maneuvers and FOT measurements in the first 2 days of life. So in a situation when we still are in the RDS situation to some extent, so the lung is probably homogeneously ventilated. And we compared this to lungs which have been ventilated for more than 7 days, where you are approaching a lung where PPD is probably already evolving. Most likely the lungs are not in a homogeneous situation anymore. Some of them might also be in RDS situation. And what you can see that also, what you can see that also in the, when you're doing this measurements in a later phase, you can still retrieve the compliance improvement measurement by the FOT. So this technique does also work in lungs, which are probably heterogeneously ventilated. I'd like to sum up these the presentation. Yes, use stepwise oxygenation guided recruitment maneuvers to open the lung during HFOV in preterm infants. And it is important that you oscillate on the deflation limb. It is also important to perform lung recruitment whenever you come across with signs of lung collapse. The forced oscillation technique can be easily and safely applied to preterm infants on HFOV, and the reactants can be used as an additional parameter, at least as an additional parameter, to guide lung recruitment maneuvers during HFOV. And last but not least, I would like to state, to repeat a statement by Dean Haas, that recruitment maneuvers should be seen not just in the context of oxygenation, but in particularly in the context of lung protection. I would like to thank all my colleagues, and I also would like to thank the very nice collaboration, acknowledge the very nice collaboration with the group from Raffaele De Lacca, Chiara Veneroni, and Beatrice Bomoni, with whom we had a very inspiring discussions on FIOT. And thank you very much for your attention. I'm happy to get your questions.
Thank you, Tobias. Thank you, everyone. I'm seeing that there are already some questions over here, and let me see, Manuel. I'm gonna start and then hand over to you. Eventually, we can stay some more minutes if there are other questions, so we can, how can I say, fulfill and satisfy all your curiosity. So the first question states, could you send an electronic material because I've wrong week? Well, yeah, if you want, we can eventually diffuse some slides with at least the data that are already published. Second question, is there a benefit to use SIMV? Won't pressure assist control work just as well? I guess that this is a question for both of you, maybe more for David.
Look, I think if we're comparing SIMV to non-synchronization in a breathing patient, then clearly I think SIMV, any form of synchronization is better than non-synchronization. I think this is well established. It's not new to neonatal or pediatric intensive care. The point I was trying to make in my presentation was not so much necessarily about each particular mode, but really the emphasis being that if you have a patient who is breathing with the endotracheal tube in place, who's on a ventilator, and has the imposition from that ventilator placed upon their system, then it's really important that you are supporting every breath that patient is making, not just some of the breaths the patient is making, because the energy need that patient has to support ventilation will be the same with every breath, not just some of the breaths. And when you have SIMV in place, it's very unlikely that you'll be supporting every breath with SIMV. There'll be some breaths the patient takes without effort. So in my view, I think that there is a logic towards using modes that support every breath rather than just some breaths during synchronization. So, but I believe that maybe that's a comment for all four of us, given that we've all got a lot of experience.
Yeah, well, I tend to agree with you. Tobias, what are your thoughts on that?
Yes, if I correctly understood, synchronization is very important when you ventilate very tiny infants, not just because of the worth of breathing, but also because of when it comes to sedation. Because when they are synchronized, you can really spare sedation, and we most of the time do not even use any kind of morphine when you have a good synchron, and in particular when you have a good synchronization, that works very well.
Okay, so another question is, Which criteria would you use to select your nasal CPAP system? I guess this is related to work of breathing, David.
Yeah, look, I think to summarize that, this is not a simple answer. I think often what we want when it comes to clinical practice is simple answers, and unfortunately we have very complex questions. And I think most of my answers are going to say the same thing, which to a certain extent is it depends a little bit on the patient and what you're treating. I think as a general rule, what you want to do is to have a non-invasive system that is going to be effective for your patient, because otherwise we wouldn't use it, correct? Doesn't matter about all the other factors. If it's not going to work, don't use it. So we need to pick the system that's going to fit your patient's shape of its face. It's going to be able to deliver the needs that you need to it, whether that's simple nasal CPAP or synchronized NIPBV or whatever. But what you would like then to reduce the imposition on the patient of having that system is to have as shorter nasal prongs as possible, or a shorter interface dealing with the patient as possible, and as wide a tube as possible, because then you're going to have the least imposed resistance from the circuit itself at the interface level. But don't think, just coming back to Tobias's comment, there's no point having a perfectly designed nasal CPAP system if the patient doesn't like having it on and they're not comfortable wearing it. So you also need to think about patient comfort as well, because an agitated patient is a baby that's using unnecessary energy and will require more energy, and that will mean more oxygen or sedation to stop that energy, and that has its own consequences. So the right one is the one that fits the best with the least amount of resistance that's imposed upon it. And I think that the Corsard study really nicely shows that what we've been using in clinical practice for a long time may not actually be the best for our patient. I think more and more we're realizing that in the delivery room, a face mask has its own complications, and maybe we could be cleverer, but I think it's still early to pack face masks away.
Yeah, that's a very complex topic, actually.
Yeah.
Can you please explain how FOT actually works with Fabian? So that's Tobias. I think it's a small recap of your presentation.
Yes, well, the forces relation technique is implemented, or it can be is implemented in the Fabian ventilator. In the it's just a module you need to activate, and you choose your mean airway pressure, and then this mean airway pressure is then given to the patient, and then you activate your FOT measurement, and it takes about and then the Fabian imposes very small very short oscillatory signals with at 5 Hertz and with a amplitude of 2 millibar to your patient for about some seconds, 2-3 seconds, and then the patient is put back to your ventilation you have chosen, and then gives you this reactance number. Yes. So it's something which is easily done. You just activate it, and during this process you see also these oscillations, but they last just a few seconds, and it's very well tolerated by the patients.
So Daniel, if I may, there are some other questions. I'm going again to the high frequency. Tobias, there is a question about the use or the potential use, invasive or non-invasive, for high frequency during resuscitation in preterm babies, or also in other kind of babies such as meconian aspiration. So any comment about that?
During resuscitation after delivery,
yes.
I understand. Yes. Well, we have some evidence, and we have also published a case report where we indeed used high frequency oscillation right after delivery in preterm babies, when the lung is a mask ventilation or by ventilation, by conventional ventilation, then you can just stick directly to HFOV and apply quite high pressures, about 18, 20 millibar, to open the lung. And then even during resuscitation, that seems to work. But there's almost no data out there, so it's difficult to recommend it, to do it regularly. But once you are not able to open the lung at all because there might be a sepsis or something like this, and you end up with cardiopulmonary resuscitation, we then think to apply quite quickly HFOV and to exert quite high pressures to the lung to trying to get them open as soon as possible. So there is probably a point for using HFOV in lungs which are not open at all. It's a bit different issue when it comes to meconium aspiration. Sometimes you are doing quite fine the first let's say 20 minutes, half an hour, and meconium aspiration, you can kind of stabilize those patients by the cost of probably very high level of PEEP. But then we also turn to HFOV when we are approaching very high levels of conventional, high level of positive inspiratory pressures, and then we might change to HFOV. And this also does work, but we also need to say that these patients sometimes then require ECMO, and you should not postpone ECMO whenever you are approaching a very severe situation for your lungs. And we are then also doing ECMO on this level.
So, David, do you want to add any other thing to this?
Yeah, I think it's really interesting in the delivery room. But I agree, for meconium aspiration, high frequency is a different topic. It's a different group. We've got to remember I think a lot of the questions in the Q&A have come up around different modes and different things. The answer to all of this is we should apply the right mode for the right pathology to the right physiology for the right baby, correct? The way we're going to treat a baby with meconium aspiration is going to be very different from the way we treat a baby with preterm baby of RDS. And the baby of meconium aspiration should be, and definitely the clinical, both registry and some randomized trial data suggests these babies will be very responsive to meconium to high frequency. But of course, and most of their lungs do need a lot of lung recruitment. But we have to understand that in that condition, because of the longer time constant, the greater resistance, the bigger baby, the larger chest wall, the amount of time you need at each mean airway pressure step is considerably longer during the open lung. So if you do the 2-minute one that's been described by Anton, it's unlikely to recruit the baby's lungs. We did some work that showed you needed at least 5 minutes and generally 10 or more minutes at each mean airway pressure step to get stable lung volume. And these babies often have a much more complicated cardiovascular condition, and recruiting babies who have profound pulmonary hypertension and an unstable left ventricle generally comes into trouble. So, whenever we talk about high frequency, I think we always have to remember before you start the oscillator, you fix the heart if you can, or else the baby may not tolerate it. The delivery room is quite fascinating because, to me, I agree, Tobias, it's really interesting to hear your experiences clinically, because we've found in our lamb work that if we put the lambs directly on high frequency at birth, they really struggle to aerate their lungs properly. And we've almost wondered whether it's because the oscillator generates too little a pressure change in the chest, and that movement of lung fluid from the airways into the interstitium is actually being driven by the positive pressure inflation rather than the wiggle and the drive. And we've struggled, and we've often found we have to do sustained lung inflations. But these were lambs who were firstly fully sedated and anesthetized, so they had no spontaneous breathing, and they had a glottis which had been taken over by an endotracheal tube, so they didn't have any ability to manage that themselves. So it's really reassuring to hear what you say in human babies, which is a more important model. because I think my wonder was with high frequency in the delivery room, whether you needed to have babies breathing to be able to help do that initial birth transition with the oscillator, in which case I think it would be useful. So thank you for the clinical data. That makes me feel a lot better.
So Tobias, there are a few questions about the practical aspect of forces oscillation, how leakage secretions can affect the measurement, and from my side, how this can be affected by the size of the baby. So what about those very immature babies with very small lungs compared to bigger premature babies?
Well, first of all, yeah, that's a very, very good question about leakage and about some partially obstructed tubes. And at very little measurements, actually, but some of those measurements didn't work because of this, yes. But when you're doing FOT and you don't get a good answer out of it, then you might think that either you have a big leakage, or you do have obstructions which do really compromise your signal. And so that might give you also clinically a hint. You try your FOT and you see the number doesn't make sense at all, that you think about, okay, what can be optimized, what's about leakage, and might there be an obstruction in the tube? Because when you have a big obstruction and when you have a lot of leakage, yes, the numbers are probably not very reliable. So you need to solve this problem first. But this problem has to be solved anyway, because it's difficult to go on with any kind of respiration mode when your tube is partially obstructed or when you have a big leakage. And when it comes to your second question, we did all those measurements in in extremely preterm infants, all below 1,000 grams. So you can do it also in 400-gram babies, and we have some information there. So this does indeed work also in these babies. And the size of the tube, we have 2.5 tubes and 3.0 tubes in internal diameter. It does not really affect your change of your FOT values. It probably affects a little bit the absolute number, but the changes are really nicely depicted regardless of the size of the tube and also regardless of the size of your baby.
Hi, Daniel. I don't know if you want to make any other comment or question, because we have only 5 minutes to go.
No, well, I think we had quite a good discussion. I wonder if there is any other from the audience.
I was going to say, Danny, there's a question, a really, I think, important question that I didn't cover around patient self-induced lung injury, which is a topic which I think many of us will know. We're hearing adult intensive care colleagues talk about quite a bit in ARDS. And it clearly is a question related to asynchrony and fatigue in acute lung disease. And I think the question there was, do you think in infants work of breathing is mainly problematic because of fatigue, or can it also be caused by PSI-LI? Are we aware of any studies addressing this? The simple answer is we have no studies which have essentially looked at patient self-induced lung injury in neonates. I think this is a fascinating topic. I can tell you that in our LAM group here, we are now doing a series of experiments where we are trying to understand the role of breathing on lung injury at birth, in particular in preterm lungs, because as many of you may know, that virtually all of the preterm LAM work, which has been done in early preterm life, which has been used so often to guide clinical strategies, has been made in fully anesthetized animals who are intubated. So we're currently doing a series of studies where lambs are randomized to full apnea or good synchronization or intentional asynchronization, and ventilating them for a period of time. And we are seeing some injury differences between those groups, which are quite interesting. So I think probably we will understand this topic better in a couple of years, but I don't know. And well, I think this is something you've been thinking about as well, isn't it? And you, Danny, if you have any thoughts about patient self-induced.
Yeah, well,
lung
I've been thinking
injury.
about that, and I personally believe that this is also happening in neonates, besides the fact that we're probably overlooking that. Even I guess there is even a little bit more risk because you see we may have babies like preterm ones that are breathing under non-invasive respiratory support for like weeks with a certain amount of work of breathing anyway. And unfortunately, we are not very good at objectivizing this because we do not measure, we do not have esophageal pressures or this type of measurements like in adult patients, at least so far. But as you said, it's a matter of synchrony. So at least we had the possibility to have a look about that. But this is something I guess that in the future will have to be taken into account because I have no clue of the size of the problem, but for sure, there will be some with a little bit of self-induced lung injury. I'm also thinking about, you see, the late treated ones that probably are not very early treated with surfactant because you say, well, it's okay, it's a big one. And these ones are, experiencing a pretty relevant dyspnea. So that may be another case when CILI could be actually there. I don't know what you guys think as well. That there is a question of pulmonary hemorrhage that's a little bit out of scope, I guess, but we can eventually answer it.
Well, I do also think that CILI might be a very important point to address in the future. At least we see sometimes babies being on Cpap the whole time, never being ventilated at all, and still having some signs of bronchopulmonary dysplasia at the end. So there is probably something which is been self-inducing to some extent, and so it's a very, very reasonable question. Yes.
Absolutely agree with all of you. Also, a matter of questions: how much oxygen we have been giving to all of those babies on non-invasive respiratory support, trying to not intubate it. Many times we increase too much FiO2 just to prevent intubation, and the risk is much more balanced against oxygen injury compared sometimes to invasive mechanical ventilation. So this is another question that we have to balance many times when we wait too much in giving surfactant or intubating a baby. So Tobias, this is only a very practical question. Any change in your oscillation when you put the baby in prone position? Do you find any kind of difference in terms of resistance and elastance?
Do you mean in the FOT values, because you need to measure this?
Yes, absolutely. Yeah.
No, not really. We are regularly changing position in these babies, and what I didn't mention here is that it is difficult. You should have a protocol when to do a recruitment maneuver. You're not just doing it like by yes, I think so, and so on. You should have a policy, a clear policy so that you can kind of stick to this policy when initiating a recruitment maneuver. And we have some data we are about to publish this, and that the best benefit in terms of oxygenation is indeed after turning the patient and doing a recruitment maneuver, either from prone to supine, or from supine to prone position. So the data we have shows that turning position of the baby and then doing a recruitment maneuver does indeed improve oxygenation, and we need to look a little bit closer in it also on the AET values and the FOT values, how this improvement is transmitted to the lung mechanics. So far, I don't see a big difference, but the change of position is a very important recruiting maneuver itself. Yes.
There are some other questions. I see here, for example, about nasal air frequency, and well, I don't know if you want me to read it, Manuel, or you want to take care of that.
Well, you can do it by yourself because it's non-invasive high frequency. Yeah, this is one of your topics.
Yeah, well, there are actually many non-invasive HFOV. What are your guidelines and settings? This is something you can easily find on the review we published in Seminars of Perinatology or Archives of Disease in Childhood. we use very high mean airway pressure in order to open up the lung a little bit like you do with the alveolar recruitment for invasive HFOV. And then there was another one that it's actually disappeared. Then again, for Tobias, did you find differences in the optimal CDP according to saturation versus reactants? And in which cases reactants identified a higher, lower optimal mean airway pressure than the saturation? So basically reactants guided versus saturation guided the recruitment.
Yes, a very good question. And our protocol didn't allow to change to find the optimal pressure for the FOT. We still applied the oxygenation guided, but what we saw is that we have some difference in the reactance measurements. So we had still a very slightly improving reactance, sometimes also when we have already approached, or when we already are at the closing pressure, meaning that probably applying, or when we would use a reactance as the guiding parameter, then we would probably end up with a little bit lower mean airway pressures, with the cost of increasing the oxygen supply. So this is now that now needs to be tested, whether we can allow a little bit more oxygen and being in a better compliant lung. That needs to be tested, and I think it's interesting, and we're about to think about how to implement such a study. And probably also in this context, there's another thing, because David also said about the time interval in each pressure step. When you are an RDS, probably you only need 2, 3, 4 minutes. But when you have a heterogeneous lung, you even need quite longer time steps. And that is what you also see when you repeat your FOT within one time step. One pressure step. Yes, when you're doing it quite 4 minutes later, then you get a number, and when you're doing it 6 minutes later, then your number is changing. So saying that you are not yet in a stable situation. This, I think David also has published a very nice paper on this using the RIP method. How long you need to actually do, how long one pressure step should last. So there are a lot of issues in there which need to be addressed. But I still think that FOT is one parameter which could help us in this situation to get a little bit better information out of the lung.
Tobias, there is another one that I guess is very easy, but also very important. And somebody says, in doing FOT, if the patient is in mechanical ventilation setting pretty high, so pretty aggressive ventilation, will it tolerate the FOT?
Yes, that what we have seen. Yes, it's just a very short period, and you take the mean airway pressure you have, so you do not completely change the lung volume during your FOT. So in these recruitment steps, obviously you have your continuous descending pressures, and then you're doing your FOT, and obviously in this part that your baby is stable. So these 3 seconds of measurement does really work.
Okay, any comments from your side, guys? Otherwise, I think we're gonna wrap up. We went a little bit late, but still more than 400 people connected, so that witnesses the interest on this topic. And please, I also want to remind to all the people here to take the survey that will appear at the end of the webinar to get the CME certificate, and obviously to follow us and possibly become an ESPNIC member. So if there isn't any other stuff, maybe Manuel, you wanna close up?
Well, just to remember all of the people who really want to keep on, touching this kind of topics and reviewing this webinar, to become a member of the ESPNIC. And now, because we have the new section of neonatal critical care, more and more neonatologists are very welcome to the ESPNIC. So thanks, Tobias and David, and thanks, Danielle, for doing this fantastic webinar. Remember, to all of the people who belongs to the ESPNIC, that they can review and look at the webinar later on, just going through the educational website. So thank you.
Bye.
Thanks. Thank you
Thank
to
you.
all of us.
Bye bye.
Thank you.
Bye bye bye.
Bye.
Okay, good morning, everyone. I am Daniele De Luca, the president of the European Society for Pediatric and Neonatal Intensive Care, and I am very happy to welcome you on this ESPNIC webinar about news in neonatal mechanical ventilation. It's a large topic, but we selected for you two wonderful speakers that will be talking about two different new aspects that are impacting on our daily activities. So I know that this is a record for us. We have more than 2,000 people register it, and we're very happy of your interest regarding ESPNIC, and ESPNIC will always be there